We do see that patients that have embryos that only reach the blastocyst stage on day 6, when we freeze those embryos, the pregnancy rate is a little lower, the implantation rate is a little lower than if the patient had blastocysts that got there on day 5. A lot of embryologists ask me, say, if we have an early blastocyst, should we vitrify it or should we wait till it becomes a more advanced blastocyst? Should we wait till it's more expanded? And when we looked at the data, this is 182 patients here who had just one embryo transferred. You can see that the implantation rate for early blastocysts is perfectly respectable. But when we looked at this data, what we did notice was that embryos that were at more advanced stages, specifically this expanded blastocyst stage here, didn't implant very well. And we wondered, what is it about vitrification that's causing those guys to have about half the implantation rate of regular blastocysts or hatching blastocysts? And one of the things that we noticed was that, these embryos, they had big cavities, big blastocele cavities, and they didn't seem to tolerate the freezing process very well. So we introduced a procedure called artificial collapse or artificial shrinkage. And what you do here is you look on one side of the blastocyst and you find a nice clean area between two trophectoderm cells, and you line up a little laser right here and you fire a shot to disrupt those junctions between the two cells. So you make a little hole right here, and then what happens is that all this fluid in the embryo sort of leaks out through the hole, and you can see that the embryo is kind of collapsing down on itself towards the hole. And now that that fluid's gone out of the center, this embryo vitrifies much more efficiently. The problem with having a big embryo like this and trying to vitrify it is that the solution in here dilutes your cryoprotectants, and you don't get the same effect that you would have if you get that solution out of there. This collapsing process seems to work really well. The first 3 or 4 years we did almost 800 FET cycles. When we started doing collapsing, we found that our survival increased pretty dramatically, up to about 98% here, compared to only 91% for embryos that we hadn't done this artificial shrinkage for. And in particular, the expanded blastocyst stage, those big embryos that weren't doing very well before, once we started collapsing them, now they're doing just fine. And in fact, collapsing seems to help other stages as well. So this is something that we're doing pretty routinely now. Another thing that we noticed was that, whereas day 6 blastocysts had lower implantation rates before, once we started collapsing these guys, the implantation rates for day 6 blastocysts were just as good as they were for day 5 blastocysts. So that's a technique that, when I talk to embryologists about doing vitrification, I say this is something you've got to do. Especially if you have big blastocysts, you've got to collapse them down. You've got to force them to shrink down and evacuate the fluid out of the cavity before you vitrify them. With smaller embryos down here, it doesn't seem to matter, but these big guys right here, you've got to get that fluid out. And then the last thing is something that was noticed a long time ago about vitrification. This was a publication by Mark Larman back in 2006. He noticed that if you take an embryo and you put it into chymotrypsin, which is an enzyme that you can use to dissolve off the zona pellucida, it takes about 150 seconds for a normal zona to dissolve away to nothing. But if you've vitrified that embryo, the time taken to dissolve away the embryo goes up almost 5-fold. And the theory here is that something about the vitrification process causes severe hardening of the zona, the shell around the embryo. And, if you get this severe hardening in the shell around the embryo, maybe when the embryo comes to hatch out of the zona at the time of implantation, with vitrified embryos, maybe they can't get out so easily. So maybe we need to make a hole in the zona, we need to make a cut in the zona so the embryos can get out. So we started doing that in 2011. These are our 2010 data right here. Same age groups as we looked at before. You see the pregnancy rates are doing okay here. After we started making a hole in the shell, allowing the embryos to escape, pregnancy rates pretty much went up across the board. We improved the process across the board for all patients. So now I'm a big advocate of not only shrinking the embryo before you vitrify it, after you warm that embryo, you should make a hole in the zona so that this hard shell, you negate the fact of the hardening of the shell, and we've seen a nice jump in our pregnancy rates as a result of that process. We also see, again, this is 2011 right here. These are the differences between embryos that got to the blastocyst stage on day 5 and those on day 6. The differences have pretty much gone away now. We've sort of taken away that effect of the day 6 embryos being worse by doing artificial collapse and by doing assisted hatching, and it doesn't matter anymore whether you have day 5 or day 6 embryos in the freezer. Your chance of pregnancy is pretty much the same. And that's great news, because in the early days, if you had day 5 embryos in the freezer, we would transfer 1 embryo in your FET, and we had a tendency to transfer more than 1 embryo if you had day 6 embryos in the freezer. now we can transfer one embryo no matter what stage the embryos are at. Other complications? Well, the miscarriage rate across all age groups, these are the same data that we saw a couple of slides back. The miscarriage rate, I think, is perfectly acceptable now. These pregnancies seem to be pretty normal, pretty straightforward, just like in fresh pregnancies. I think the data are looking good, and I think when you show patients this data right here, it's getting easier and easier to convince them just to take one embryo back. We did have some monozygotic twins last year. Particularly in our ovum donor program, we're not exactly sure why. It might be something to do with the zona hardening, but we don't really know. But this is something that we're sort of watching, and we're still seeing a small number of patients getting twins, even though they're transferring just a single embryo. So we're trying to deal with that right now, but I think other than that, everything's working pretty well. So on the day of a frozen embryo transfer, when a patient comes in, we just warm the embryos, less than an hour before we actually do the transfer procedure itself. So a patient is coming for a frozen embryo transfer at 10 a.m. The embryologist will typically start warming the embryos at about 9:30. We do assisted hatching after warming, and we keep the embryos in culture for a very short period of time, and then we put them back into the patient, and that seems to work really well. So has vitrification helped our program? Yes, it has. It really has helped our program. We're doing 60% of our ovum donor recipients are now doing elective single embryo transfers. I think that's fabulous. We've done a lot of cycles of single embryo transfer so far, and the pregnancy rate is really good across the board for people who take a single embryo. So, we can tell patients, you've got a really good chance of pregnancy, and even if you don't get pregnant after your single embryo transfer, your frozen embryos will be here, and you still have a great chance of getting pregnant from your frozen embryos. If we look at cumulative pregnancy rates from one retrieval, a patient who does one retrieval and then transfers one embryo, and if they don't get pregnant, then they use some of their frozen embryos. So they only do one IVF cycle. 80% of our ovum donor recipients took home a baby. This is not a pregnancy rate, this is actual take-home baby right here. 80% of ovum donor recipients took home baby. About 2/3 of patients under 35 took home baby after just one egg retrieval, one IVF cycle. And unfortunately, we still have a small rate of twins across the board, but we're working on that. Anybody interested in vitrification, I'd strongly recommend Dr. Tucker's book that he put together with Jürgen Lieberman from Chicago. It's a great book to have in your lab on the theory and practice of vitrification. I refer to it all the time. Last slide, I would just like to acknowledge all the hard-working embryologists that I have in the lab with me in San Francisco. Here's my email address right here. If anybody would like a copy of my slides, or if you have any questions, you want to email me after the fact, here's my email address. And I thank you for your attention. Everybody's so quiet, huh?
Thank you, Dr. Corrigan. So we can open a discussion.
If you don't have the money to buy a laser, can you collapse into the super needle?
This is a very common question. A lot of IVF labs, even in the United States, where patients are paying cash a lot of time for their IVF cycles, a lot of IVF labs still don't have a laser, because the laser for us, it's a $30,000 piece of equipment. Right? So a lot of programs don't have a laser. You can collapse them with a needle. You don't have to collapse all your embryos. You really just need to collapse the embryos that are at that expanded blastocyst stage. If the embryo has started to hatch from the zona, it tends to be more fragile and it collapses on its own just from pure handling. It's those big expanded guys like the day 6 fully expanded blastocysts or really advanced embryos of day 5. So you can stick like a needle, an ICSI needle in there, and you can either suck out the fluid or you can just make a hole and allow the fluid to drain out. There's actually an even easier way than that to do it, which Michael talked about in our talks yesterday. You can put the embryos into a solution, some medium containing 0.1 molar sucrose, and that'll collapse them right down to it. Yeah, because to do the ICSI needle, you've got to set up the micromanipulators, and it takes time and effort. If you make up a collapsing solution with some 0.1 molar sucrose, then there's just you put them into that solution for a minute, and then you carry on and go through the vitrification process. So I'm a big advocate of doing it for those big embryos, and there are different ways to do it if you have to.
I have a question. Maybe I didn't understand very well, but you say that it's better to wait a little bit more before making the transfer of the embryo. And instead, in the talk of Dr. Tucker, I think he claimed that it's better to make a transfer earlier. So I didn't understand very well this different claims.
Opinion. Yes.
So I think we're talking about waiting to do the transfer on day 5.
Yeah.
Right? I actually don't think that it's better. I don't personally, I'm European, right? I'm from Ireland, right? So I think us Europeans, we don't like doing, keeping embryos in culture for long periods of time. I think this is something that's really sort of developed in the United States, and that's very popular in the United States. And in the US, I think patients are stimulated perhaps a little more aggressively than they're stimulated in Europe. So perhaps we have more eggs and more embryos that we're working with for a given patient. And when you have a lot of embryos, then I think one way to choose which embryos you're going to transfer out of the big group is to just keep them in culture for a long time to see which embryo develops the fastest, which one gets to the blastocyst stage first, and then you choose that embryo for transfer. I think there are many promising technologies in the pipeline that will allow us to identify which embryos are healthy or which embryos are most viable without having to keep them in culture for very long periods of time. And Michael talked about one of them, the Unisense machine, where you look at the cell division profiles of the embryos and you get a handle on whether the embryo is healthy or not very early in the process. And I actually, I'm sort of very invested personally in that technology because I think we should be doing embryo transfers on perhaps day 2 or day 3. And I think if we do go back to doing earlier stage transfers, then perhaps we will see a lot less of the sort of epigenetic effects that we see as a result of, I think, are a direct result of having embryos in the lab, the artificial environment of the lab for too long. So yes, we do transfer embryos later in the United States, but I think that's, for us, it's the way we cope with the fact that we have perhaps a lot of embryos and we don't have right now good technology for deciding which ones are the best. But I hope that will change, and I hope we will go back to doing earlier stage transfers.
And it's an important tool to give us maintain high pregnancy rates for the cash-paying patients, but at the same time attempting to reduce twinning or triplet rate. But we know it's perhaps not ideal. Even though, as an embryologist, I think it is a real privilege to keep embryos out for a long period of time, we may be doing more harm than good.
I have two questions. What about the differences from traditional cryopreservation of embryo and vitrification? And another question is, in a poor responder patient that have few oocytes and few embryos, which kind of protocol do you recommend?
In your second question, on the poor responder patients, if we only have one embryo or 2 embryos, then we will do the transfer on day 2. As soon as we see fertilization and embryo development, we will put the embryos back into the uterus right away. So typically, we choose extended culture. We choose to do day 5 transfers when the number of embryos that we have is more than the number of embryos that we want to transfer. If the number of embryos we have is very low, then we will transfer the embryos much sooner. Now, for those patients who have very small numbers of embryos, if we want to do a single embryo transfer, we think that's in the patient's best interest, we can vitrify the surplus embryos at earlier stages. We don't have to wait until day 5 to do the vitrification. This procedure, the exact same protocol, it works very well with zygotes, with fertilized eggs, works very well with day 2 embryos, works very well with day 3 embryos. So this protocol is very flexible, and you can use it for any embryo at any stage, and it seems to work really well. Now, to go back to your first question, the differences between traditional cryopreservation and vitrification.
About implantation rate. Related to the implantation rate.
Yes. As an embryologist, I have spent many years slow freezing embryos. And Dr. Tucker, I'm sure, can share his experience. We've done that for a long time. And in the early days, when I was a young embryologist 20 years ago, we were freezing embryos on day 2 and day 3 using slow freezing. The technology worked, but it didn't work very well. As embryologists, we would often find ourselves thawing an embryo on day 3, and some of the individual cells would lyse within the embryo. Sometimes all of the cells would lyse and the embryo wouldn't survive. Sometimes 1 or 2 cells would lyse, and we think, okay, most of the embryo is still alive, but maybe its implantation potential is reduced.